David, it's trivia time. What's the
Okay.
ninth, what's the ninth letter of the Greek alphabet in the name of a bar in Arlington, Virginia that held a monthly poetry series for more than 25 years?
I know you used to participate in that, and you are a very good poet. I'll give you credit for that. But I gotta say, I don't know the answer to this.
Well, I appreciate the compliment, and I have to give a shout out to my friend Miles David Moore, who's a local DC-based poet who hosted that series for all the 25 years. And the bar was called IOTA.
Oh, really? Okay, I
Yeah.
see where you're going now.
Yeah, and it was a very small place, hence the name. Although it expanded, I remember joking with the owner, like, "Does that mean you have to change the name?" And he didn't think that was very funny. Um, so why do you think I am asking you about the word iota?
Because we are going to be talking about IOTA, which in this case stands for Increasing Organ Transplant Access Model, that has been released by the Center for Medicare and Medicaid Innovation at CMS.
So the acronym is IOTA, all in caps. So the IOTA model, I think, interesting choice by CMS, but to call it that, but an important model nonetheless. So what do we need to know?
What you need to know most importantly from the beginning, and we will be coming back to listeners with some more details in the coming weeks. But for the moment, what you need to know is um, we are very relieved to see that the Innovation Center has very much listened to a lot of things that were discussed in the last couple of years. And this is a much more straightforward, much more simple model than what we had in the ETC. And I think a lot of people did feel that the ETC was it was very complicated and it was very
And,
difficult.
and just before we move on, can you just give us the one sentence sort of description of ETC and how it compared to the other model, et cetera?
Uh, the ETC model was well, it's all there's some comparison because they're both mandatory. It's a mandatory model that we're still currently operating under that comes out of the executive order in 2019 that was designed the ESRD treatment choices model, and it was designed to increase both home transplantation, excuse me, home dialysis and transplantation with various metrics and various upside payments and downside payments.
So just so I'm clear, there were two models related to the delivery of care in the hopes of increasing home dialysis and transplantation. One was mandatory, one was voluntary. And now
Yes.
we have a third model, IOTA, which is a transplant focused model, which is also mandatory. So ETC and IOTA are both mandatory.
That's correct.
Okay. So what else did you want to highlight about IOTA before we start to get into some of the more specifics?
Okay, so when you think about IOTA, they basically have first you must understand that this is really going to mostly include as participants kidney transplant hospitals. So kidney transplant centers is what CMS often calls them. They will be the ones who will be randomized with half of the donor service areas in the country, DSAs, being represented by these hospitals. So, but possibly about 90 is what could be expected. And there's a way for nephrologists to be incorporated into the model. It's a little different. We'll get to it a little bit later, but it does go after a couple things. It's very, like I said, it's very straightforward. They tried not to be complicated. They wanted to maximize the use of deceased donor or kidneys. They wanted to increase access to kidney transplant by actual transplant numbers, not waitlisting numbers, but transplant numbers. They wanted to improve quality of care and coordination of care, and they wanted to really try to make sure that access to kidney transplant was not impacted by equity issues. And that's not just race or other issues that are kind of often looked at. Also, low income assistance and socioeconomic factors are also being put on the table. So it's a fairly straightforward model designed to get more people transplanted, and it will last, excuse me, and it will last 6 years.
So as I'm listening to you and the sort of goals, as you describe the goals in the model, they seem pretty well aligned with a lot of ASN's policy priorities and things we've been advocating both to CMS and CMMI, but also more broadly in the legislative and regulatory branches. Do I have that right?
You do. You do. You have it absolutely correct. The government prepares these models and releases them. They do talk to people. And so ASN has had the chance to really has worked on this and kind of provided input for over 2 years. So this is a really a very, very aligned model with what ASN has been working on, how to create greater access, how to deal with the equity questions around it, how to make sure that actually it was a transplant that occurred, not just the act of waitlisting somebody. And also transparency. There's a provision in here that requires patients to, on a regular basis, to be provided with an update of the number of organ decline offers that their center made on their behalf. And that is not something that the average person on the wait list now finds out about.
Yeah, and you mentioned the 6 year time span. So just so I'm clear on that, this year, 2024, they would move from the proposal to a rulemaking process and I assume, solicit public comment and organizations like ASN, other members of the kidney community, other members of the transplant community, individuals sort of participate in that. Then they'll go live January 1 of 2025. And as you mentioned, it is a mandatory model. And then 25 through 2030 would be 6 years, if my math is correct. So help kind of walk us through kind of the next steps here.
Well, first of all, they have said you are correct. Your math is correct. And they have offered up a chart and kind of a timeline for starting January 1. They have also asked for comment about whether or not that would be appropriate time. They seem to be a little less concerned about whether it's January 1 but just that it's ready to go in 2025. So you're talking about January 1. They also did an alternative model start date that they proposed or offered, excuse me, which would be July 1, 2025.
And
So
why would they do that for a mandatory model?
It would just depend on the feedback that they got, particularly from transplant centers. If there was a strong argument to be made that some of the steps that needed to be taken in advance were going to take more time than what would be allowed in the last part of 2024. So that's not what I don't think that's an unreasonable thing to be included.
Yeah. So basically they didn't want to sort of paint themselves into a corner. So they're saying we want to start January 1. However, if we receive a lot of feedback or a lot of concerns, we'll give ourselves till July 1, but we're still committed to going forward and this still being a 6 year model.
Yes, that is what I mean by the simplicity, the much more simple openness of this model. There are several places in it where they have left themselves open to kind of how the system would most properly improve itself. And so, for example, on the equity question, they are going to require transplant centers to develop an equity plan for really how to improve equity and equitable distribution of organs in their center. And in all honesty, I mean, each individual center probably does know what they need to do in their community to increase equitable access. So they've given some guardrails about things that should be included and considered, but they're not requiring it to be a certain set of, let's say, off-the-shelf metrics. And you have the first year to develop your equity plan. And so you don't have to have it January 1, but you do have to have it by, let's say if they start January 1, you do have to have it by December 31st and 2025, and you've got to send it to them and they've got to be able to review it. So it is a lot more open-ended in that way.
So, David, I'm going to move next to where some of the potential pushback could come from and why as part of the rulemaking process. Before we go there, though, I do want to shift to our producer, Lauren, because I know she's been working really closely on this and see, Lauren, it'll be an open-ended question. Is there anything David said that you disagree with that you want to challenge him on? Or is there anything you want to add or any other comments you'd like to make? So you can go in any direction you'd like.
That is a very open-ended question. I think David did a really good job running down the basics. I think it's important to stress that we're still combing through the details. The rule itself is 381 pages. So we're currently going through it page by page, getting all those details put together, and hopefully we'll we'll come back with more details on this. I think it's just also important to stress that this is a very highly anticipated model, and we've been waiting for it for months. So we're happy that it's finally here, and we're looking forward to see how it goes.
Oh, go ahead, David. Sorry.
I was going to say when Lauren, when you were talking, and I know we've talked about this. One of the things that I did neglect to say is it does exclude the transplant of a kidney for anyone under the age of 18. So
Yeah.
it includes it just excludes pediatric programs. You have to have done at least 11 kidney transplants in your center for adults. Am I right on that, Lauren?
Yes, you're exactly right. So in order to be included in the model, you have to have at least performed 11 kidney transplants annually, and pediatric transplant centers are excluded from this model. So anyone under the age of 18.
Yeah, and just to give people a frame of reference as to what 380, 400 pages are, that's like reading Little Women and then being asked to provide a detailed sort of summary and catch on page 250, you know, something that others may miss. So, you know, I think combing through is probably exactly the right way to describe it. So David, before we invited Lauren into the discussion, I was curious about potential headwinds or opposition or challenges to this. Change is difficult. As you mentioned, these efforts are coming. You know, it's interesting. If I take a step back and I think about CMMI, and then I think of the executive order. So we had the Affordable Care Act in 2014, moving forward and creating the CMMI, the Center for Medicare and Medicaid Innovation. And then we had the executive order in 2019 establishing federal policy for goals around the kidney care. And one of the key pieces was a dramatic increase in the amount of home dialysis and transplantation. And we have seen progress in each of those. And at some point, we should probably do a summary podcast where we describe all of the advances, both in home dialysis and transplant policy. However, with this specific model, because it's mandatory and because it is in the transplant arena, I anticipate some pushback. Where do you think that's going to occur?
Well, you know, I don't want to speak for people who, I don't want to put myself in other people's shoes. There are different ways in which they look at it. I don't expect there to be a lot of patient pushback because it really does try to address a lot of things that patients have talked about, and it does not in any way prohibit a patient. Let's say that the transplant center you're listed at is also randomized into this model. You're not required to stay on that list. You still could go to another transplant center that's not in the model and get transplanted. It would not affect you at all. So you still have that option to do it. So I don't expect there to be as much trouble there. There will be some concerns about some basic things. And one of those basic things would be whether or not the model has a powerful enough financial incentive to do what needs to be done. The other area where I think there could be some real concern and pushback is there are pieces of this that are still ongoing within the organ procurement transplant network and its programs at the moment. But I mean, I think another area that's going to be really interesting to watch is CMMI does not have the authority to override what other agencies in HHS are doing. So in particular, HRSA, the Health Resources Services Administration agency, excuse me, they have various standards and they have various practices ongoing right at the moment under the OTAG group, the Organ Transplant Affinity Group, that I think could conflict with some of the things that are in this model. And how that's going to get resolved, I don't know. I think we're definitely going to be raising those concerns.
Yeah, so David, one thing just to correct something I said earlier. So the Affordable Care Act was signed into law in March of 2010. What I was thinking of in 2014 is when people started enrolling after they started the marketplace. They enrolled in 2013 and then started. But again, I was off by 4 years, which tells you how time has evolved over the last decade plus. I think you make a really interesting point about HRSA. My sense, and I'm just curious, this is a broader issue, and I'm curious as to what Lauren and you think, is that one of the challenges with transplant policy is it's spread more across the Department of Health and Human Services than other, like if you're trying to influence home dialysis or you're trying to influence Medicare, graduate medical education funding, you're going to very specific agencies. But with transplant policy, there's a HRSA piece, there's a CMS piece, Centers for Medicare and Medicaid Services. There's all these different agencies that have kind of a touch on it, which I think it makes it really hard to do these sort of transformative changes, including a mandatory model.
Absolutely. And in the future, in our next broadcast on this, I'm going to include my colleague Rachel Meyer, who's been working on a lot of those issues in HRSA as well in this conversation, to go into some of how this breaks down. But the bottom line is, in dealing with this issue, the whole overall jurisdictional issue over transplant, ASN has been absolutely supporting and advocating for an Office of Kidney Health and Transplantation at the Secretary's level in HHS.
Yeah, it's a really good point, because I think that ultimately, if you had more centralization around transplant policy and around kidney policy, and if you think of the Venn diagram there, that should help to address some of these concerns. Because I think a lot of problems we've had over the last 50 years, since the Medicare ESRD program started, I think has to do with the fact that these policy initiatives are just spread across the government. And it really has, I think that the executive order really exposed that, which is interesting, because I'm sure that was not one of the intentions, but it clearly has been a collateral result of that effort. I guess my final question is, what's next? Can you just sort of walk us through kind of the next couple steps?
Well, I do want to add one thing to what you were saying, but one that I think all of our listeners will really understand. It also has led to basically a set of very difficult to break down silos. And I think ASN has been making a lot of headway on that issue, but it still is an issue. And so there's a part where kidney diseases pre-kidney failure are kind of siloed into one space, and then those people who are undergoing dialysis are siloed elsewhere, and then transplant is siloed elsewhere. So it has taken numerous steps all along the way to be able to try to move all of the pieces on the board at the same time. It is a lot like chess. There's a lot of different pieces. But the next step is there's a 60-day comment period. Anybody listening to this can go online, and you can contact the policy department at ASN, but you can go online in the Federal Register and make comments on this proposed rule. Because it's a mandatory rule, it does have to go through rulemaking. And so that will be in July. That'll be in the second week of July. That'll be the first thing that will happen. And then they will go into final rulemakings, and that will then probably be another 60 days. So you're looking at possibly mid-September for this to be actually fully announced. And then that's when we'll also have an actual start date. And we will definitely be talking about this. I know when we get to people, we'll be talking about this when we get to Kidney Week. But it's a very exciting thing for transplant patients. And the possibility that we really could drive the numbers up.
Well, great. Well, thanks, David. Really appreciate you taking the time to have this conversation. And Lauren, thanks for all the work you're doing in terms of ASN's response to this initiative, but also all the moving parts in the regulatory. We'll come back to in the next couple of episodes, I anticipate, is all the forthcoming proposed rules related to the relationship between the Medicare program and the 37 million Americans with kidney diseases and the 12,000 U.S. nephrologists who care for them.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.